Kathy, are you retired now?
You are mute, Kathy.
Mm-hmm.
Yes, it was 4 years ago yesterday.
Gosh, just like remember meeting you in New Orleans with Daisy.
I know. That was the last time. And that's just...
I thought you had, but then I've seen your post, but oh my gosh. It's great to see you. Yeah, you're involved, but you were such a tremendous leader.
Oh, well, thank you. Yeah, those are very kind words. Very kind words.
Yeah.
And, when COVID came along, why it just really put a pause on everything.
Yeah. I feel it. Yes. Well, mention a little of that, kind of, not really. I don't promise not to talk about COVID. I kind of refuse to discuss it.
I know.
I don't want to talk about it.
As far as the world of simulation, it really, I think, pushed simulation into more virtual and simulation.
And it's got its place, but it's not everything.
Right.
At some point, as I say, the students still have to practice inserting a Foley catheter. You can play all the virtual games you want. You still have to finally open that tray and do the task.
Right. I agree. Yeah.
It's more important than ever today because they don't get to do it in clinicals.
Or maybe I'm just old. I don't know.
No.
Do all the things you want, but at some point you finally have to do it.
Right.
Feel the stuff.
Right. Well, Nelson's right. They don't get the clinicals that they used to get.
No, I realize, but that's a whole other topic for another webinar for another day.
Yeah, really.
Yeah, totally. Yeah, well, my name is Daisy Mercado. I'm a simulation educator in Mayo Clinic, Jacksonville, Florida. That's my new role. And now I'm the leader of the Florida Alliance for Simulation for the Southeast area. And thank you, Mariano, for keep us together here. So today I have the pleasure to I'm sorry, what? Okay. Yeah.
Hi, good evening, everyone. My name is Nelson Pena, and I'm a simulationist down here at Baptist Health, South Florida, in Miami. And now most of the south part of the state, we keep getting bigger and bigger. Again, I'm in charge of the Southern District down here. So welcome. I'm glad you could all make it to our meeting today.
Hello, my name is June Lorena. I'm the Simulation Curriculum and Development Director at the University of Tampa, and I am one of the leaders for the Suncoast side of Florida. Welcome.
Yeah, I saw Cindy too. Okay. Today I have the pleasure to introduce one of my colleagues and friend and classmate from the Master in Simulation, Elizabeth Horsley. She began her nursing career as an operating room nurse nearly 30 years ago. Her involvement with simulation began in 2005 with the initial round of funding for simulation in nursing education from the province of Ontario. Over the past 15 years, Elizabeth has focused her career on all areas of simulation, from the theoretical basis to best practices of implementation and facilitation. She has pursued numerous educational opportunities, including a master's degree focusing on simulation, advanced debriefing and curriculum design courses, and the Certified Healthcare Simulation Educator designation. In 2017, she was recruited to the Brooklyn Hospital Center, where she's working now, to develop and implement a simulation program. Elizabeth is very involved with the Simulation Society and the International Nursing Association for Simulation. Most recently, she was a member of the writing teams for the Healthcare Simulation Standards of Best Practices, focusing on pre-briefing and simulation design. She's a self-admitted hoarder of simulation resources, and her passion is helping novices learn best practices for developing and implementing their own simulation programs. Here's Elizabeth.
All right. Thank you, Daisy. And it's so good to see you. Said Daisy and I were in the, oh, sorry, just excuse me. For a moment. Sorry.
Well, you know it's live.
Sorry, just had to. Okay, I'm sorry. There we go. Daisy and I were classmates at Drexel, the first class to graduate in that program, but also got a great affinity for Florida. My first nursing job, 1994, was in the operating room at St. Joe's Hospital in Tampa. There, if you can believe it or not, there was no jobs in Ontario at the time, so I was part of the mass exodus of Canadian nurses that went down. So I was there for about 18 months and then went back to Ontario. You know, had my life and kids and all that and simulation, and then ended up through the Drexel program, getting recruited down to get a simulation program started in this hospital in Brooklyn. We thought it would be just a year and a fun thing to do, and now it's over 5 years. But should be wrapping up. My work visas will finally have all run out by early next year. However, I think I need to join the Southwest then portion of this because we just bought a place on Marco Island. So
Wow,
part-time Floridians. So I think I just need to join this organization once and for all. So yeah. I'm really happy to be here today with this presentation. Now, I created this presentation, as I say, I don't know about you, but I feel like life is divided into before COVID and after COVID. So I know I developed this before COVID, pre-briefing, debriefing feedback, so called PDF of simulation. So I've sort of updated it a little bit today, and I'll explain as I go along. But I want to say, though, it's also what I'm talking about today is general principles. And I don't know about you, but as I said earlier, I'm not going to talk about COVID today. And also, I'm really not going to talk about virtual. What I'm talking about are general best practices. I think I almost feel in some ways the last while we went, and rightly so for many reasons, but we went so heavy into talking about everything virtual. I almost feel like we forgot about in real life for a while. So it just feels good to come back and just talk about some of these basic principles that really are the foundational building blocks of our simulation activities. But for today, our presentation, our learning objectives, we're going to talk about some best practices for pre-briefing. I'm hearing myself. Debriefing. And oh, I'm sorry. We're going to discuss. You know what? Pre-briefing. I'm so your voice and your presentation. You know what happened? I copied some of these slides from another presentation where I had done voiceover recordings, and I thought I had taken it off. I'm so sorry. That was my fault. All right.
I thought you were practicing ventriloquism.
I know. It's magic tricks too, right? I'm really... Okay, so what I'm going to talk about today then is some of the best practices for pre-briefing and debriefing, identify some strategies, and the other thing I want to talk about the importance of creating the psychologically safe environment. But the first thing I want to talk about, and when I say this new standard, now some of you may be familiar with the INACSL, so International Nursing Association for Clinical Simulation Learning. Some of you may be familiar that they had established best practice guidelines. I believe the first iteration was around 2011, 2013 or so. And, very good over time. The problem was, though, is people assumed they were only for nursing and they were only for academic nursing. Over just before COVID had started and then finally released in 2021 was the latest iteration of these standards. And they're now renamed as the healthcare simulation standards of best practice for best practice. Not only that, but in the writing of these standards, they made a very concerted effort to have interprofessional teams on them. Now, I know there's a couple people from Florida. I know also not only interprofessional teams, but also teams made up of people from academic and from practice settings. So we've been really working to get the word out that these standards are applicable for everyone. They're not just this nursing, academic, undergraduate nursing programs anymore. If you haven't seen them, do have a look. I'm going to refer to the pre-briefing and the debriefing standard today. You can find them easy enough. If you can't, my email is on the last slide. So I will send you, you can reach out to me and I can send them to you if you want more information on them. But over the course of these standards, they've added new standards with each iteration. This last iteration, they added a standard on pre-briefing. So that period, those activities that happened before the simulation experience itself. And what happened is over time doing practice analysis, surveys with the membership, people really started identifying that there were specific activities they needed to do in that pre-briefing period. So pre-briefing, it's not necessarily a new concept. It was always sort of alluded to. It was alluded to in your design standard. Have you, talked about what you want your learners to do at a time? It was alluded to in your facilitation standards, or it was always there. Even within the debriefing literature, you would always often see some mention to make sure you mention before the scenario starts that there's going to be a debriefing at the end. So there was always, it was referenced, but it was always kind of all over the place in little bits. It was never in one place. So what we did is got together and made a brand new standard. So when you think about pre-briefing, though, you're talking about preparation, what you want your learners to do ahead of time, what you want them to know, your briefing, which is that information you're giving them just before the activity itself, and together that's the pre-briefing. And also, I will talk about too, for those of you on this call who are in clinical practice settings, because that's what I'm representing, I went down the rabbit hole and I found examples of pre-briefing that can be used for your in situ activities. So I will talk about that a bit, and again, something you can reach out to me about. So these standards, what I've done, these are what are called the infographics of them. You can get the entire printed copy of I know I'm sitting in the westerly facing windows right now, you can see that. So this is just a printed PDF of the standard. They also come in these formats of these infographics. Again, you can find them online or just email me and I will get them to you. So I just want to talk about the pre-briefing standard for a minute. So the pre-briefing standards divided into universal criteria, preparation criteria, briefing criteria. And I'm just going to walk through the steps of these. So your universal criteria is your simulationist should be knowledgeable about the scenario. So it's not just a matter of, oh, who's available, is there faculty, can you go in and do that? Your simulation should know what the scenario is, the STEM, the patient, what the objectives are, the outcomes, what's happening here. Your pre-briefing is developed according to the purpose of the learning objectives, and you're considering the experience of the learners. So your novice learners, you may want them to really have more preparation. You want them to really have more, or if they've never been in simulation before. Okay, so what do they know? Or they've been to the lab. Do they know how things work? Do they, how a simulation will go versus your senior level students versus your practicing professionals. So, and a lot of this comes into developed according to the purpose of the learning objectives. Over the last few years, as I've done more and more work of simulation, I know I teach a lot of the CHSE readiness review courses. I teach some other courses. And I think the two things that I talk about the most, needs assessment, learning objectives. What are the objectives for this scenario? What is it we're wanting to do? And they drive everything we're doing. So those are just your universal criteria for the standard. Now, your preparation criteria. What is it you want? What will help your learners? Your simulation time is valuable. We were just talking about it's hard to get clinical placements, but Benford, I'm by virtue, yes, we're using simulation more, but we have more students in our programs. We don't maybe have as many trained facilitators as we like. So your time is your time is valuable. How do we maximize that time in the simulation space? Give you an example as I was doing a project and I was reviewing one school's debriefing practices. So I got the videos and I reviewed it, and it was all right. I mean, the debriefing itself was fine. However, I was stuck with, it was a preeclampsia scenario. And how much time the facilitator had to spend reviewing the basics of preeclampsia with the learners. Now, and to me, those were some things the learners probably could have reviewed ahead of time, then come to the scenario, and you might have been able to have a little more robust and reflective dialogue in your debriefing. So think about what your learners can know ahead of time. Do you have some meds you want them to know? Do you have a care pathway you want them to know? Do you want, just review your ventilator settings when you come in? Know what do you know your normal lab values? What are the things your learners can know ahead of time? And you can do this a variety of ways. I said, one of the biggest things, lots of big things have come in the last years. A lot of people finding ways to combine virtual then with their simulation. So they have their learners doing a lot of virtual activities to prepare them for the actual in real life scenario. If that's an area you're interested in, let me know. A lot of groups from back home in Ontario have done a lot of work in that area. So I can certainly send you some of the things there. So what do you want your learners to know? What will help them? What will make them more comfortable? I'm going to tie this all into psychological safety at my very last point. So just thinking about that, and this is the thing too, is one of my colleagues on the writing team for this standard, and she called it ambush simulation. In the early days of simulation, I think you know what I'm going to say, Kathy, because I can see your face. Just throw them in there. Don't tell them anything. Second day of nursing school, let's do a mega code and just see what happens, even though they don't have a clue, right? So you want your learners prepared. And what happens with that? They get upset, they get overwhelmed, their cognitive load is shot, and they hate simulation forevermore. I mean, when I was at the NAXL conference last week, and people saying, now the new grads coming into the hospital, and they all hate simulation because they've been scarred from experiences like that. Let's just throw them in. You want your learners to succeed. And what is your simulation for? If this is a formative simulation for learning, then let's do everything we can so it can be as meaningful as possible. Now, this last point here in the preparation period, deliver prior to and on the day of the simulation. Now, I want to say prior to. A lot of people, and when we've been presenting on this new standard, like, well, what about in the hospital? What about with mock codes? What about with in situ? Isn't pre-briefing defeat the purpose of your in situ? I will give you an example. The hospital over here in Queens, New York, and they rolled out a program with their staff for in situ simulations for stroke codes. And what they did is they crafted a letter to everyone who might be involved in these activities. And it was sent out within the next 3 months. At some point on your shift, we're going to do a code around our stroke code policy and procedure, our care pathway for strokes. You may be involved. This is why we're doing it. Because simulation, they explain the benefits of simulation. This is for your learning. It's not for punitive. We're not evaluating you. No, we're not writing up. This is for you to learn so we can provide the safest possible care to our patients in acute stroke status, so we can provide the best care possible. If you're interested in seeing a copy of that document, let me know and I can send it to you. So just when we say pre-work ahead of time, it's not always just meaning your students doing something, but letting people know what simulation is, why we're doing this. Instead of just walking onto a hospital unit, dropping it and saying we're doing a mock code now, People don't know why. Why are we doing this? One of the things I've seen a lot in the literature with problems sometimes with those activities is immediately staff thinks there's something punitive going on. Is there a report going on? Did we do something wrong? Why are you doing this? Letting people know this is for your learning. So if you're interested in those elements, please reach out to me and I can share some of that with you. And then finally, your briefing criteria. Set the tone, the logistics, what's happening today, who are the roles, who's taking part here. This is who you are, this is how many people, this is your patient. How many of you have watched your students during a code blue, right? They're frantically opening and closing the drawers of the crash cart because they don't know where anything is. Think about everything you can tell your students ahead of time so that it will make the scenario go that much easier. Think about something as simple as SimMan. Do you want them just to take the blood pressure by pushing the button on the monitor, or do you want them to do actually a manual blood pressure? Where are things kept? If they need to hang a medication, where do they get supplies? I saw a great presentation from the University of Michigan at Flint. They have a video they've prepared that all of their learners need to watch prior to simulation. How does the bed go up and down? How do the side rails work? How do you turn on the oxygen? What if you want to call the attending physician? All of these things that the students need to watch ahead of time. And they said they can tell in the debriefing if somebody did not watch that video like they were supposed to. So just thinking about those things. But the other thing I want you to think about too, and I'm going to go switch over to the academic setting for a moment, is I have gotten over, I love it when I find a really great creative activity. And think about that pre-briefing period as a time where maybe you can get your learners together to work through the case. Maybe they could design a care plan. Maybe they could start a concept map. One of my colleagues who wrote this standard, she used to be over at the University of Miami, but she's since gone back up north. And she has a wonderful paper. It's one of my all-time favorite papers. And she has this method she calls know, do, teach. Prior to the simulation, her learners come together in a group and get a whiteboard and they write down no. What do we want to know about this patient? What do we need to know? Do, what do we want to do with or for this patient? And finally, teach. What kind of patient education are we going to be doing? Brilliant. You have your group work through it. This sort of piggybacks to another area that I've done some work in is simulation with large groups. As I said, I do some work with University of St. Augustine's. I'm not sure if any of you from there are on the call, but we've talked about this. When you're getting large groups, what kinds of activities can you do so everyone is involved? Planning ahead of time. Let's work through what would we do. My feeling with doing those kind of group activities before the scenario, again, this is assuming your scenario is for formative purposes, is your learners are working together with what they want to do. Then maybe you have 2 or 3 students who actually go in to be the practitioners. I feel like that sort of removes some of that anxiety from your students feeling they're in the fishbowl. They're more or less just the messenger for what the group decided, if that makes sense. So thinking about all those things ahead of time, letting your learners know, again, simple things. If you need to call the lab, if you need to call an attending physician, the patient's family member will be here. If you need to get this information, get here. Walk through and just think of all those things that will make this just run more smoothly. But finally, creating that sense of psychological safety. One of these days I need to write a paper, but I probably won't because I'm a terrible writer. But if I had to put simulation down, the 3 things, and if somebody wants to copy this right now, go ahead, but I call it the holy trinity of simulation. Patient safety, experiential learning, psychological safety. Psychological safety is that sense you create for your learners that they are in a place where they can take a risk without fear of reprisal, without fear of consequences, that they can jump in, that they can try it out, that they can go into the scenario. Okay, and this is what they found. The more comfortable your learners are, the more apt they are to be active participants in the scenario. The more active they are in the scenario, this should translate to a more robust debriefing. And from this debriefing, hopefully then you close those performance gaps, you identify those frames, you have them reflect, and you get that learning across, and in the end, we have safer patient care. So it's those, like I said, those students in the first week of nursing school where you've thrown in the mega code, they feel like they don't belong there, they want to quit, they want to become crossing guards, they don't care anymore, and they hate simulation for the next 2 or 3 or 4 years or the rest of their career. You want that psychologically safe environment. Now, if you have not read a paper called Establishing a Safe Container for Learning by Jenny Rudolph and the team at the Center for Medical Simulation at Harvard, you need to, after you're done listening to me, you need to go read that paper, or at least you need to read that paper before you work with students or learners again. It's one of the all-time great seminal works in simulation. If you don't have it, please email me or I'll email Daisy tomorrow and we can get it out to you. It's called Establishing a Safe Container for Learning by Jenny Rudolph. And it talks about these these concepts of the psychologically safe environment. Now, I mean, there's some people you may hear, they don't like the word, is this really safe and safety? And there's all kinds of things around the nomenclature and what we call it. But ultimately, what you want to do is make sure learners feel this is a place where they truly can come and learn. You know, in the old days of simulation, right? Frog marched them in the room and they didn't do it right. And then afterward, you had an instructor, I lectured on that last week. I can't believe you don't know that, right? And then they're just all left. So I just want you to think about that and have a look at that paper. So that's kind of your pre-briefing. I've actually really enjoyed when I got on the committee to start writing these standards, and I was just assigned to pre-briefing, and quite honestly I never really thought that much about it, but now that I've gotten so into it, I can see it just sets the tone for everything, and there's just so much room for you to be creative as an educator with some of the things you can do with your learners. So just said, I've done entire presentations on this topic, so it's hard for me to shift gears now and move on to another topic because I love this one so much. But by all, and the other one is the No Do Teach. I can send you that paper. So it's by Donna McDermott. She actually just finished up at the University of Miami, so it's a fantastic paper. If I were back in nursing education, I would be forcing it on everyone because I think it's just a fantastic, fantastic activity to do with your learners. Couple of these wise words. Dr. Kim Layton. Kim Layton is one of the all-time greats in the simulation world, and I quote her all the time. And she said, the learner should know the context within which they will be expected to perform. So there used to be, you know, sometimes used to be this debate in simulation. You tell the learners the objectives or don't you? You need to give them an idea. You don't have to give them everything. For example, let's say you're doing a post-op, very simple patient's day 2 post-op. You want the students to get the patient from bed to chair. You want them to do a set of vital signs, but you've built the scenario so that their blood pressure drops. What are the students going to do? Critical thinking, right? You don't need to tell them all that, but you do need to tell them you will be caring for Miss Mercado and it's day 2 post-op. Okay, so you're giving them something. Again, that whole concept, well, that's the real world. We're not going to tell them anything. Well, I would disagree. I would say even the busiest trauma unit in Florida right now gets some kind of a call or a heads up. Something is coming. I shudder to think if we had healthcare professionals going in to see patients and they don't know anything at all about them. So they should know the context. And the other one I like is David Hallowell. If you don't pre-brief, you spend your debrief talking about the mistakes you didn't mention in the pre-brief. So you can, again, think about that time you're taking ahead of time. You can save a lot of time in the end if your learners are prepared for what they're doing. So this is, I'm going to switch gears now to the debriefing of it. This is just a little diagram that I came up with, just an overview of debriefing. This is a very simple one that I have actually prepared, and I give it out to educators in my hospital to help them guide their debriefing. You know, they're just learning. So generally, as a rule, your debriefing is divided into 3 phases. Either you can see it called the reaction or the gathering, the analysis or the understanding, and the summary, and that can take 2 forms, but I'll explain that in a moment. So your initial reaction, how did that feel? You might want to, you know, just that sometimes if it's a very heightened emotion one, you may want your learners just to be able to decompress, diffuse a little bit. A synopsis, sometimes you might want to get to someone just give us an overview of what this case was. 55-year-old male presented to the ED in VFib. Something just so you know everyone's on the same page, a shared mental model, so to speak. Then you get into that analysis or understanding phase, the bulk of it. We'll talk a little more about this, and there are different ways. What worked well and why? What was easy? What was challenging? Daisy, if you remember, it was Sharon Callman said to us at Drexel, debriefing lets us get inside their heads. And I've always remembered that. Also, two really important concepts in debriefing: frames and performance gaps. Frames are the perspective, the lens, the way your learners are coming, everything that's with them. This is that constructivism theory that they're bringing to it. Okay, what are their backgrounds? Were they in the military? Where they have a little different background than anyone else? Were they a nurse's aide and then they became an RN? You know, what perspective is everyone bringing? What is their frame? So I'll give you an example as a colleague of mine, and she had been in the Navy. And you can correct me, anybody who's in the military here. In a mass casualty with the military, your priority is the walking wounded, getting them back out to go. A civilian mass casualty, your priority is your most severely wounded. So just after she came out of the Navy, she was involved in a civilian mass casualty drill. What do you think she did? She went to the walking wounded first. So in the debriefing, and they said, what was that? Can you explain, your rationale? But when she said, this is the rationale. Oh, okay. What are people's frames? Getting at why your learners took a certain course of action or inaction. Performance gaps, you think of it, what your learners did, what you wanted them to do, and how do you close that gap? Getting at their frame, what led them to this, and through a period of reflection, combined with your feedback, combined with your direction, closing that performance gap, or as I like to say, solidifying it. I just generally think we don't give enough positive strokes in this world. So I like to say, if they did something really exceptional, point that out. Wow, that was some really great therapeutic communication you did with the patient and his wife. Have you worked in an area like this before? Find out, right? So I like that. And finally, the summary. And two things there. What are the points you wanted them to have? Everybody identify a take-home message. What are you taking from this experience you're going to take forward into your practice? But the other thing, again, Daisy, this was from Sharon Callman at Drexel. What did you want everyone to know before they walk out the door? And I'll tell you, even when I'm designing a scenario, anybody comes to me and they want to do an activity in our hospital, and I have a clipboard, and I have a piece of paper on it in big letters that says, what do you want them to know before they walk out the door? And that's the basis for everything I do in simulation. And then make sure you capture that again in your summary phase. So again, real overview of debriefing here. Again, we can go so far down, do it. I could do a series of 5 presentations, but that's just kind of said in this little model. Again, any of my scenes, I'll send you my slides, anything at all. So the debriefing, as I said, the standards of best practice that have come out, and the debriefing one was updated. There's always been a debriefing standard, but now it's been updated. So I'll just kind of quickly review it. The nice thing, I will tell you, the biggest shift in the debriefing standard from previous iterations of the standard is they've really taken into account feedback, reflection, and the debriefing. See, it used to be, and maybe I only because I see you here, but Kathy, you might remember, people have been in simulation a long time. It was like there's debriefing and there's feedback. And never the two will meet. Like you're either doing one, you're doing the other, but we're not doing both. Or within the debriefing, can't give feedback. Everything has to be bi-directional and reflective. But now they've looked at there are times for directive feedback. If your learners really have not grasped the necessary rate and depth of chest compressions, it's okay to review it with them in the debriefing. It's okay. So this standard, I like it now because they've included feedback in there. And there's really become, I think, more of a shift to looking at, of course, in debriefing, you want to do the reflection, you want people to make the meaning, put things together. But there are times when that directive feedback is also necessary. So ensuring your debrief, I like this, conducted or designed or facilitated by a competent debriefer. Debriefer is not just a simple, easy skill. Oh, well, I'm tenure track. I can debrief, of course. I've been a bedside nurse for 147 years. Of course, I'm an excellent debriefer. Of course I can do this. Well, I'm an expert at this. I have a PhD in biochemistry. Of course I can debrief this. It's a specific skill set, and like any other skill set, it requires practice. It requires a lot of different situations for you to be really confident, for you to be able to react to all those nuances, manage the group when things are happening. You want to promote self, team, or systems analysis. So that's another thing. In the systems part, they mentioned that. Thinking about your in situ, your mock code activities in your hospitals. A lot of times those aren't necessarily about medical management. They're about system issues. Why does it take us so long to get from our ED to the cardiac cath lab? Why does it take us so long to get to first shock? So looking at those system issues and planned and structured in a purposeful way based on theoretical frameworks. I think I'm going to bring this up next. Debriefing frameworks. This is just a smattering of what's available. But without a structural framework, debriefing is just a conversation. You need to have, and again, some of them, they come in different ways. I can send you different literature on them. The good judgment, that's reaction, analysis, summary, or gather. The GAS, that's the method that came out of the American Heart Association that was developed. Pearls, a lot of people talk about, but it's a blended style. So depending on the objective, depending on the level of your learner, do they need directive feedback? Can we do some self-assessment? What went well? What was challenging? Can I get in more reflective and getting into their heads? Tell me what you were thinking there. Plus Delta, that's kind of the one you hear the most. A lot of times people starting out, thing with their plus Delta is though, it's fine. You get your whiteboard and you draw your plus and you make your little triangle, your delta sign, and you make all these lists, but then what? You see that people make all these lists. Well, we did this, or we need to change this, then what? So what? So I had a professor once always used to say, so what? What are you doing with that information? The other one I want to point out here is rapid cycle deliberate practice. That's something, if you're doing something that's very algorithmic in nature, you want to go through your ACLS algorithms, your shock pathways. You want to go through proning a patient. Those are things where, as I said, there's really not a lot of room for debate what we're doing here. And in a nutshell, with rapid cycle, you would go for a minute, 2 minutes, whatever, stop your clock, do what they call a micro debrief. What's happening right there? Where are you? I actually did a course on this one time. And they actually, before COVID, obviously, like physically move you into position of where you should be standing. Like take you by the shoulders and no, you're better off if you're standing over here, if you're standing here. So physically going through it, start your clock, go again. Still a form of debriefing, but think about it in terms of things. I always just use the word algorithmic. Postpartum hemorrhage. What are we going to do? There's, again, not a lot of room for debate. These are the steps we're going to take.
Finally, with
I did that again. That's another one. Okay. Sorry, I thought I'd erased all of those. Then speaking on feedback, and really interesting, I just got on and did a lit search and just looking at seeing if there was any new papers in these fields. And I actually came across a really good one today on feedback, talking about feedback, different kinds of coaching. Again, I can send it out to you if anybody's interested. But just some things around feedback, though. It's really interesting. A couple of years ago, I went to a simulation symposium, and the keynote speaker was Mary Beth Mancini. She's a nurse from Texas, phenomenal. And she said the two most important things we should be doing with our health profession students today is teaching them how to give feedback and how to receive feedback. The only way you're going to grow, the only way you're going to learn, the only way you're going to become the best practitioner possible is through getting feedback. And, so many reasons we could go into why. I'm not just going to say the millennial or whatever the generation is now. A lot of people have trouble getting feedback, but we're giving it to them to help them grow, to help them get better. But I like this no more sandwiches. That tell them a good thing, tell them a not so good thing, tell them a good thing. All that does is sound disingenuous. As Daisy, you remember our last course at Directive, Tony Arquette, and he said, can we not just have authentic conversations? And that's what you should be doing with feedback. Identifying learning versus performance goals. When I describe these two kinds of learners, you're going to know exactly, those of you who are in academia are going to, in your head, separate your students into these two groups. Students, learners with learning goals, I want to be the best nurse possible. I want to be the best physician possible. I want to be the best respiratory therapist possible. I want to be the best occupational therapist possible. I want to learn everything I can and contribute and do what I can. Performance goals, I want my GPA, I want my A, I want my 4.0, and I want it now. And I know you can separate your students. Those with a learning goal orientation are more receptive to feedback. What do I need to know to be better? Okay, as opposed to just wanting that grade. Learners, they want credibility. They want somebody they feel they trust. They want somebody to feel giving help. I started out as an OR nurse back there at St. Joe's in 1994 in Tampa. And as I say, as much as I talk about giving students positive strokes, by God, if you contaminate the sterile field, I'm going to tell you. Okay? And there's not a lot of room for debate. We just had our surgical interns had the orientation today. And I said, if anyone ever tells you you contaminated something, you contaminated it. Do not ever argue. You contaminated the sterile field. That's it. End of discussion. So I mean, looking at those things, the source. Also keeping in mind too with feedback now, think about all of the things we have: hepatic devices, even you've got laparoscopic simulators, the GI, the bronch, telling you how many times you hit the bowel wall, how much how long your bowel was insufflated for in your colonoscopy, all of these things. So just keeping in mind all those different kinds of feedback, but then incorporating these bits of directive feedback into your debriefings if necessary. And it's a complex skill. Debriefing's not necessarily instinctive. We kind of think, well, I'm in healthcare, I know this, I've done this for a long time, I should be able to do this. I do a little presentation in our hospital on difficult communication and empathetic communication. I'd rather start the most difficult IV in the world in someone's baby toe than sometimes have an empathetic conversation with a patient in a difficult situation, right? It's very different. These communication things, I hate it when they call them the soft skills because they're not really. There's a lot to them, as well as the psychomotor and the task. Find the framework that suits you best. I know some of you at your school, you may have one style of debriefing you've adopted, you use all the time. Other ways, you may have different things for different purposes. The gas might work. I said it came out of the American Heart Association, so it may work for some of your activities. Rapid cycle might work. You were doing a palliative care scenario, so maybe you wanted to approach it a little differently. So find out what works for you. Knowing how to blend things is necessary. Also, you're basing your debriefing and your learning objectives, but knowing where something unexpected happens in your scenario, how do you pivot and maybe start covering them? There are instances where maybe you need to supersede what your original objectives were and cover something unexpected that happens. I like debriefers often have good intentions. We're all learner-centered. Of course I'm learner-centered, but the minute they get an audience around them, it becomes another lecture. Okay? How do you prevent that from happening? Or when is it okay to teach? Sometimes you may have to. Higher level debriefing skills. I've got a wonderful paper by Adam Chang, who created Pearls, Vince Grant, the team out in Calgary, Alberta, Canada. And it's called A Toolbox for Difficult Debriefing Situations. Actually, Daisy, I have all kinds of resources in debriefing I'll gladly share with anyone. Not kidding when they said I am a hoarder of simulation resources, but I will gladly share my collections with anyone. And debrief ongoing assessment. The DASH tool, that came out of the Center for Medical Simulation at Harvard, debriefing assessment simulation in healthcare. Even if you're not using it, it's a fantastic resource just to see what are the criteria for a really exceptional debriefing. It's always worth having a look at. And I do like this though. You can have the sim man that jumps out of bed and does a jig and washes himself and, speaks. You can have mannequins that do everything. You can have like real arms on the table. You can do everything you want, but great technology, you can have all that. But if you don't have competent facilitators who know how to do this, it really doesn't matter. I saw a great quote one time. You should be able to do simulation on a campfire if you have to. We've done some great simulations I've seen in RER. They've taken a Sharpie and drawn a face on a pillow. It's about your needs assessment. It's right for your learners, your learning objectives, how you facilitate, and how you get that debriefing going. One of my favorite quotes, make it safe, make it stick, make it last. And there's my email address. So I think there's some questions in the chat here. I don't have it open. I know I covered a lot of material there. I love talking about, in each one of these things, pre-brief, debrief, feedback, I can do my own presentation on, but I love to talk about these things anytime, reach out. I love to recommend things I've read that I like. So thank you very much. Oh, I got an amen there. I wonder what I said.
Everything.
Oh, there's the Jenny Rudolph paper. Thank you. No, do teach. Oh, thank you. Thank you. Thank you. Oh, thank you. So I feel good. To be honest, I said just going back, we got so down, and again, the rabbit hole for legitimate reasons, no doubt, of virtual activities and that. So it feels so good to just be talking about the in real life skills again. We put out a call for an abstract for IMSH, and we tried to think of ideas on behalf of the hospital-based section of the vice chair. And I said, how about just a good old school debriefing presentation? It just seems like so long since anyone's had one, right? And I couldn't believe the overwhelming response I got from people. So that's great. Other thing too is, if any of you are ever interested, I also I do facilitate the Certified Healthcare Simulation Educator, the CHSE, cheesy, however you want to say it, courses. So if you want more information, I do the courses, but I certainly have a few resources I've collected over time that I think are helpful. It was funny, I think during the height of COVID, there's a simulation Facebook group. I'm sure there's quite a few, but one I was in, and people, I guess, while they were home, thought they'd prepare for the CHSE. So I sent these collections of resources. I got quite busy just sending them to people, but people really liked it. So I always say I'm not the sharpest knife in the drawer. I'm not a scholar. I'm not an academic. There's a reason my career is, my terminal degree is this master's degree in simulation. So when I find papers that are written in a way that they're practical, that you can understand, I love papers. I love papers that are a descriptor of something someone did. We developed this curriculum. We based it on Kern's curriculum development model. This is how we did it. So that's a lot of what my collections are, things like that I found. I'll tell you is, I had a question. I found these two papers one time. One of them's on theoretical basis and simulation. The other one's on simulation modalities. Wonderfully written, comprehensive at a great level. I'll tell you, I found them in the Journal of Pediatric Urology. I promise I don't subscribe to that journal. And they're just amazing. So by all means, I will send them to you.
Okay. Well, thank you, Elizabeth. Yes, you're doing great. We really appreciate it. Any questions from the audience?
Thank you on the presentation. This was very, very well. Very well received.
Thank you.
If you want to come back down to the Tampa area, I'm more than happy to have you.
But yeah, my first job there, St. Joe's,
We take our students there.
and then I lived up off of Dale Mabry Highway on West Humphrey.
Yeah.
But it was fun, and you know what? I'm Canadian, right? So we all had our mandatory French school. I had to do my life over again when I was in Spanish. There was they were all Spanish in the room, and the surgeon would just look at me and say something in Spanish. I just go up the hall and grab anything that's open. This is what you wanted. I don't know. I had my interview there, and they said, how do you handle, surgeons can be very temperamental, and we have one here who's really, to this day, still figure out who they were talking about, because it could have been any of them. Great job, though. I loved it there. I haven't been back, but I loved it there. You'll get down when I'm on a Marco sometime. I guess the closest to Naples.
Yeah. Yeah.
Right?
So,
Oh, Cindy, hey, how are you? How are you? I didn't pull up my list of who's here because when I'm presenting, it's cognitive overload for me. My slides are more than enough. So I didn't. Glad you're here. Thank you. Thank you for sharing with us. Oh, anytime. I love it. So I'm really excited. So anything I said, like I said, my email is there. Daisy has my email to me through Daisy. I'm glad
She's actually doing professional development. We are training our SOSs this coming week. We try to do monthly professional development. And then we were texting the mom, and she's like, this is basically the PowerPoint reading for SOSs.
That's, you know, I can send you whatever you want. I'm all about sharing with people. All about it. I'm all about it. When somebody tells me they have CHSE, you know, I'm all about sharing it.
Wonderful. Thank you.
Right?
Great. Well, thank you, Steve, for joining us. Thank you, Elizabeth, for presenting, and Daisy for helping arrange. Elizabeth coming with us, and Mariana for all of our marketing and sharing all of our resources and speakers on all of our different social medias. I also wanted to let you guys know that I am stepping down as chair of FHSA just for personal reasons with my husband's passing. I just have too many plates in the air. Just thank you for everything. I really enjoyed being your chair for the past few years. And transitioning from the affinity groups to non-affinity groups for SSH. I think we've done a lot the past few years. Done a wonderful job getting our website up and running, getting our membership pieces in there, and getting all of our FHSA emails out, and things done a wonderful job getting speakers every month, and we've written our bylaws. I think we've come really far the past few years, especially as a non-affiliated group. So I just wanted to thank everyone for their contributions. And I'm still part of the team, and I just wanted to share that I should go and give myself some space. So thank you for everything.
Thank you. Thank you. Thank you. Okay. Well, thank you, Elizabeth. And we hope we can do us a little bit. Thank you, everybody, for participating in the meeting. And see you next time. We'll let you guys know that it's going to be the next meeting. Thank you. Thank you. Bye, guys. Thank you.